Hi, I'm Ruth O'Regan. I'm the Chair of Medicine at University of Rochester. So the BRCA genes are breast cancer related genes, are genes that predispose you to breast cancer. So there's two genes, the BRCA1 gene and the BRCA2 gene, that will be determined when you see a genetic counselor and have blood tested to see if you potentially have a mutation that predisposes you to breast cancer. Now, the BRCA1 gene is associated with breast cancer, and in particular, what's called triple negative breast cancers that don't express estrogen receptor, progesterone receptor, or HER2/neu. The BRCA1 gene is also associated with ovarian cancer, and not only do you have a higher rate of getting a primary breast cancer or one breast cancer, you're also at a higher risk of getting a second breast cancer. And that's why in a lot of cases, patients who have either BRCA1 or BRCA2 mutations may elect to have bilateral mastectomies as their surgical treatment of choice. The BRCA2 gene is a little bit rarer. It actually tends to be associated with estrogen receptor positive breast cancers, and has a slightly lower rate of ovarian cancer than the BRCA1 gene, but it is associated with other cancers, including pancreatic cancer and prostate cancer in men. So what does it mean if you have a BRCA mutation? Well, BRCA1 is associated, as I mentioned, with triple negative breast cancers, and particularly a set of triple negative breast cancers that are called basal-like breast cancers, which make up about 80% or so of triple negative breast cancers that we see. Now, if you look at some of the laboratory studies that have been done, what was shown was that breast cancer cells that are BRCA mutated appear to be particularly sensitive to platinum agents such as cisplatin or carboplatin. And there's been a number of studies done that have looked at a single agent, either cisplatin or carboplatin, in patients with BRCA1 or BRCA2 or indeed BRCA2 mutations, basically showing that they do appear to be a little bit more sensitive to platinums. The data is not very clear-cut, though, because in the metastatic setting, there are some studies that have shown that, yes, these agents are more effective in patients with BRCA mutations, and then in other studies, it's been a little bit less clear-cut. But overall, I think the data would suggest that in a patient with a BRCA mutation, we may be more likely to consider a platinum agent than we would in a patient who did not have a BRCA mutation. The other very important thing about these agents is that we have now a targeted therapy for patients with metastatic disease who have a BRCA mutation, and these agents are called PARP inhibitors. There are two of them currently approved, called olaparib and talazoparib. And they're very interesting agents because what they do is the way the cancer cells divide involves what are called DNA repair mechanisms. So if you give a PARP inhibitor to a patient who has a normal BRCA gene setup, which basically is involved in DNA repair, what happens is the PARP inhibitor actually does damage the DNA. But the problem, what happens then is that the BRCA gene comes in and fixes the DNA. And what that basically means is that the cell will not die. However, in a patient with a BRCA mutation, what happens is if you give a PARP inhibitor, it damages the DNA, but because there's no BRCA to fix the DNA, the cancer cell dies. So it's called synthetic lethality. And it's a very interesting concept because the BRCA mutations are only present on the cancer cells. They're not present on normal cells. So by that end, what it basically means is that these PARP inhibitors specifically target cancer cells and avoid toxicity to normal cells. Unfortunately, not completely, but that kind of is the rationale behind them. So they're really very interesting drugs. And what's very exciting is that at the ASCO meeting this year in 2021, there's going to be a very important study that's looking at these PARP inhibitors in patients with BRCA mutations with early stage breast cancer. So we're very excited about that because we're hoping that will show that these agents will improve outcome for patients with early stage breast cancer, which could potentially prevent recurrence of these cancers and actually hopefully cure patients from their breast cancers. So overall, the whole BRCA story has been extremely interesting because we've known for many years that these genes predispose patients to both breast and ovarian cancer, but now they're kind of like a marker of therapies that can help us make more concrete decisions for our patients. So if I see a patient who has a BRCA mutation with early stage breast cancer, if they've got a triple negative breast cancer, they usually have a BRCA1 mutation, I may consider using a platinum agent in addition to standard chemotherapy in the preoperative setting to basically decrease the size of the cancer and see if the treatment is working. In the metastatic setting, also, if I'm going to use chemotherapy in a patient who's got a BRCA mutation, I will probably lean towards using a platinum because we believe that they're a little bit more effective. However, in the metastatic setting, as I mentioned, we already have the approval of the PARP inhibitors, which we certainly would use in patients with metastatic disease. If they've got estrogen receptor positive breast cancer, we'll usually treat them with endocrine therapy initially and then reserve the PARP inhibitors for later on in their course of treatment. However, there's some data suggesting in patients with triple negative breast cancers who have a BRCA mutation that if you use a PARP inhibitor first line, it actually not only prolongs the amount of time the disease is controlled, but it can actually improve survival as well. So really very exciting because this is kind of the first targeted therapy that we've actually had for patients with BRCA mutations. The other thing that was shown last year is that there are other mutations that you find when you do genetic testing on patients, such as PALB2 mutations, which again do predispose you to breast cancer. But the really good news is what we're actually seeing now is that in patients who have PALB2 mutations and metastatic breast cancer, that they also appear to benefit from PARP inhibitors. So again, this is another really good example of a targeted agent for patients with metastatic breast cancer that also have BRCA mutations.